All right, let's jump right into this rapid-fire explainer. We are running through a continuous, high-yield dermatology clinical review to really pressure test your clinical reasoning. No messing around today, so let's hit question 1 on epidermal anatomy right out of the gate.
Question 1. The human epidermis is primarily composed of which cell type, and exactly what is its embryonic origin? Well, the answer here is keratinocytes derived from the ectoderm. They make up a massive 90% of this continually regenerating epithelium. And hey, as a quick exam pearl to just keep in your back pocket, always remember that melanocytes arise from the neurocrest, and Langerhans cells, those are bone marrow-derived dendritic cells, they actually originate from the mesoderm.
Moving straight to question 2, we're looking at the structural proteins of the adult human dermis. In completely healthy skin, dermal fibers are predominantly made up of a classic 4:1 ratio of type 1 to type 3 collagen. It's this exact structural cocktail that gives our skin the mechanical resistance, the elasticity, and really the baseline tensile strength it needs to protect us every single day.
Okay, snapping over to question 3, which focuses on tissue regeneration. Imagine a deep, partial thickness skin injury. Which structures are stepping up as the primary source of new epithelial cells? You've got to look to the pilosebaceous units and the sweat gland ducts. Because these structures dive deep down into the reticular dermis, their surviving germinal epithelium literally acts as the critical reservoir for reepithelialization. It's exactly how the wound heals.
Right into question 4. Which systemic medications are most heavily associated with life-threatening Stevens-Johnson syndrome and toxic epidermal necrolysis? We're talking about severe, immune-mediated conditions that trigger widespread keratinocyte apoptosis and epidermal detachment. The high-yield culprits you absolutely must have memorized for clinical practice are aromatic anticonvulsants, think phenytoin, sulfonamide antibiotics, allopurinol, and oxycodone NSAIDs.
Question 5 asks us to define a specific Staph aureus infection. A furuncle, which you probably just know as a boil, is a deep-seated infection that originates from one single hair follicle. Now, unlike a superficial impetigo or a more diffuse cellulitis, a furuncle actually breaches that follicular wall. It bursts through to form a highly localized, super painful dermal abscess with a central core of pus.
Let's look at the presentation in question 6. We have a 2-week-old infant with a rapidly growing, bright red, rubbery lesion on the cheek. Crucially, it was not present at birth. This natural history points directly to an infantile hemangioma. These benign vascular tumors go through this explosive, rapid proliferative phase during the first year of life, and then they hit a prolonged phase where they just gradually, spontaneously involute. A lot of times they'll just resolve completely on their own over 5 to 7 years without needing any aggressive surgery.
Question 7. What is the single most common skin cancer, and what's its specific subtype in the United States? It's basal cell carcinoma, or BCC, by a landslide. It is by far the most frequently diagnosed malignant tumor. And for your clinical pearl here, the nodular variant is the most common clinical subtype. Classically, it presents as this pearly, somewhat translucent papule with rolled borders and those prominent telangiectasias.
Question 8 digs into the pathogenesis of cutaneous squamous cell carcinoma. So this is our second most common skin cancer, and it typically arises from a very well-documented premalignant lesion. You know the one, an actinic keratosis. It's that rough, scaly patch induced by chronic UV exposure on sun-damaged skin. That early cellular damage directly sets the stage, paving the way for progression right into an invasive carcinoma.
Now, question 9 covers staging for primary melanoma. Based on current guidelines, what are the top 3 independent prognostic indicators for localized primary cutaneous melanoma? You've got to zero in on tumor thickness, that's your Breslow depth, the presence of microscopic ulceration, and the mitotic rate. Make no mistake, these 3 factors are the absolute primary drivers of survival when we're dealing with localized primary melanoma.
Building directly off that staging in question 10, let's say a patient undergoes a wide local excision, and their sentinel lymph node biopsy comes back positive for microscopic metastatic melanoma. What's the most significant prognostic factor now? Well, once regional nodal disease is confirmed, the absolute number of positive lymph nodes takes the top spot. It becomes the single most important survival indicator for that specific regional basin.
Question 11 asks for the primary anatomical site of the initial pathological insult in hidradenitis suppurativa.
This is a terribly debilitating chronic condition, and it fundamentally begins with follicular occlusion of the pilosebaceous unit, specifically within apocrine gland-bearing skin. It's that initial keratinous plugging that starts the whole cascade, leading to ductal rupture, severe local inflammatory responses, and eventually, the devastating sinus tracts and scarring that are just so characteristic of the disease.
All right, question 12 focuses on Merkel cell carcinoma. This is an incredibly aggressive neuroendocrine skin cancer. And what's fascinating here is that the Merkel cell polyomavirus is actually clonally integrated into the genome of roughly 80% of these tumors. It plays a massive, direct role in oncogenesis for a cancer that frankly behaves a lot like small cell lung cancer. It has a very high propensity for early lymphatic and hematogenous spread.
Question 13 highlights a massive, really dramatic shift in skin cancer epidemiology for our immunosuppressed patients. See, while basal cell carcinoma is significantly more common in the general population, this ratio completely flips for solid organ transplant recipients who are on long-term immunosuppression. In this specific highly vulnerable group, squamous cell carcinoma actually becomes up to 65 times more common than BCC. And not only that, it behaves much more aggressively, which is exactly why rigorous clinical screening is non-negotiable.
Hitting question 14. You've got a changing lesion that is highly suspicious for melanoma. What is the absolute gold standard diagnostic technique? It is, without a doubt, a complete narrow excisional biopsy with a 1 to 3 millimeter margin. And crucially, this has to incorporate the full thickness of the subdermal fat. Why? So your pathologist can accurately measure that vital Breslow depth without compromising the tumor architecture. Shave biopsies easily ruin this critical depth assessment, so you've really got to avoid them here.
Finally, question 15 rounds us out by covering melanoma-wide local excision margins. For an intermediate 1.5 millimeter thick melanoma, say on the thigh, standard consensus guidelines require a full 2 centimeter excision margin. Just to review, melanoma in situ needs 0.5 to 1 centimeter, while anything greater than 1 millimeter in thickness demands that full 2 centimeter margin to really minimize any chance of local recurrence. And that wraps up this clinical explainer. Honestly, think about how many of these presentations walk into clinics every single day. Are your diagnostic instincts sharp enough to catch the subtle ones before they progress?